Um, I'm gonna start. Hemodynamics is really dear to me. I really enjoy the beauty of hemodynamics because it actually mixes physiology, physical exam, echo, and hemodynamics all together. And once you understand really hemodynamics, you can really have a very deep understanding of each circle of these all together. You can correlate it very well. It's a big topic. I'm just going to start with the basics. I'm going to teach you the approach to hemodynamic tracing analysis. And this is my personal approach, and then you can develop your own. But it's based on fundamentals. How hard the disease you're gonna face or mixed pathology, you're gonna be able, with this approach, you're gonna be able to analyze it. Hence, one of the few cases, but you're gonna see if you go really methodologically, you will reach to the right diagnosis in a timely manner. So what do you need to know for hemodynamic tracings? You need to develop an approach, interpretation of pressure tracings. You want to identify what type of chamber is that, atrial, ventricular versus arterial. Even though you know where are you with your catheter, but it is very crucial in a congenital heart disease where interpreting those pressure tracing is crucial regardless of where you think your catheter is positioned within the heart. 2, you want to know your hemodynamic calculations. And 2, then you have to develop a disease-oriented correlation of hemodynamic tracings, whether you have a stenotic pathology, regurgitant pathology, hypertrophic cardiomyopathy, diastolic heart failure like constrictive pericarditis versus restrictive cardiomyopathy, which is a classic hemodynamic tracing that usually we like to challenge because a lot of intellectual, and it's one of my favorites actually, pathologies that need a separate session if you understand the approach to hemodynamics in this presentation, inshallah. Tamponade physiology, congenital diseases, and approach to pulmonary hypertension. So I'm gonna talk about the approach, and then I'm gonna select few cases. We can't get all over the pathologies, but inshallah in future sessions or my colleagues will cover those. So when you approach the hemodynamic waveform analysis, 3 things. You want to identify what kind of rhythm is there. That's gonna really make different. We have an AFib or have a sinus, a bundle branch block that really change how you're going to analyze the pressure tracing. 2, identify what type of waveform, and that is it atrial, ventricular, or arterial, and whether it's right-sided or left-sided, and then you correlate the rhythm to the wave. And based on that correlation, you can characterize which is systolic event or diastolic event, and identify the pathologies accordingly. Second, once you analyze the waveform by identifying the rhythm, the wave, and correlation between the two, then you want to see what happened. You want to say what kind of what chamber is we are analyzing. So you're going to answer 4 questions. 1, you want to see what's happening in diastole in the pressure tracing. If you see there is an upslope, horizontal, or downslope pressure tracing, that's going to tell you how to differentiate between arterial, ventricular, atrial, which we're going to see it in the next slide. You want to look at the timing of pressure peaks to the EKG. So each QRS, you want to see where the pressure peak actually correlated to that. How many waves for every QRS? Is there a dichrotic notch or a wave in the pressure tracing? By answering those 4, you can confidently recognize which pressure tracing you're analyzing. Is it atrial, ventricular, or arterial? So here, as you see, the timing of the rhythm and correlated tracing, ventricular tracing, and arterial tracing, whether it's right-sided or left-sided. And you can see here, actually, you know that from echo, in the peak of the QRS is where systole starts. And the end of the T wave, that's where diastole starts. In between, in the pressure tracing, as you see here, it's actually mainly two waveforms. In the atrial pressure, where you're going to have an X descent and a V upslope. So both of those are systolic events in an atrial tracing. And you can see in the ventricular and arterial tracing, you only have one peak. Compared to the atrial tracing, you have A and the V. You have two peaks for every QRS. The difference here in the atrial tracing, where the V peaks at the end of T wave, compared to the atrial and arterial and ventricular tracings, the peak is within the STT segment. In the atrial tracing, you can see there's a dicrotic notch. That's the only in the arterial tracing. Compared to ventricular and atrial, they don't have that. But with the ventricular and atrial tracing, they have both an A wave. So those are the characteristics you can differentiate between an atrial, ventricular, and arterial tracing. You can see here again, always correlate the rhythm, never analyze the pressure tracing without the rhythm. So you go down with the QRS, you know here is where systole starts. You see, this must be your X descent. And then you have the V upslope. And then at the end of T wave, or within the T wave, you have the end of systole. And those are two are systolic events. Other than those, X descent and the V upslope are diastolic events. So this slide summarizes what I'm talking about. Atrial, ventricular, arterial. So how many waves for every QRS? We said atrial pressure, you're gonna have two waves, except in few situations. If you have AFib, then you won't have an A wave, right? So that's why if you didn't look at the rhythm, you would not recognize that. Two, sometimes if you have a large V wave, sometime in the severe tricuspid regurgitation, then it's gonna take over the A wave and blunt the X descent. But in general, you have two peaks within atrial pressure. Compared to ventricular arterial, you have one peak only. So that's number one. Number two, the timing. We said the peak of the ventricular arterial are within the STT segment and the rhythm analysis. Compared in the atrial pressure, the V wave peaks at or after the end of the T wave. How does it look in diastole? Go back. In diastole, you can see the atrial is actually upslope. Sometimes is horizontal, but it is not downsloping. So that's helpful. That it's atrial. Compared to ventricular arterial, they're always downsloping. So that's the differentiating features of atrial, ventricular, arterial. And it's very helpful here because always the ventricular always downsloping compared to ventricular and atrial pressure tracing. So if you know this, then you really have a good grasp on analyzing pressure tracings. So now to implement what we've learned, we're gonna go over cases. Are you with me all? Any questions before we start with the cases? Abdulaziz, you're the moderator.
Yeah, I'm looking at no raised hands. We can go ahead. Well, the first case is going to be done يعني taken by Dr. Saleh.
Very good. So I'm gonna, I want you to understand a few things. What is the difference between dampening versus ventricularization when engagement of coronaries with your catheters? And the second question I want to put in your mind, why ventricularization happens, okay? And if it happens, why you see your consultant or the technicians screams at you that take out your catheter or be careful not to inject. So you want to know why it's so dangerous. And then I want you to have a differential why it happens. Before you engage the coronary and after you engage, it's a very different differential in your mind to deal with and have a different management. So you have to have methodological way, the shotgun approach to make sure what is the problem in a very efficient time. So here, this is an example of how dampening happens. And when you say dampening, both the systolic and the diastolic goes down together. And you can see here, both they are really going down here. And this is what we call dampening. Compared to ventricularization, you see here the arterial tracing, okay? One peak, dichrotic notch, down sloping, up, back again, up, back again. And then you see the difference. Now, between the peaks, it's becoming horizontal here. And you start to see an A wave. And this is start to get ventricularized. Now you're gonna ask me a question. How do you know that? Maybe the catheter is within the LV, it jumped from the aorta, and then it happens a lot, right? So the key here to know that is that when you look at the diastolic pressure, usually in the LVDP, when you go to the left ventricle truly with a catheter, it's gonna be with in the premises of the 10 millimeter. Compared here, it is not, as you see, 50. So this is a hint that you're really within the artery, but actually the catheter is really not in a good position, and that's why you have a ventricularized pressure. So what's the difference between dampening and ventricularization? When it happens, it makes you worry that it's occluding the flow. And when you occlude the flow, especially in the RCA, as you know, you have the conus branch and they have the AV node branch. And the AV node branch, you can have easily complete AV block with that. But more seriously, when you block the flow with contrast, contrast has no oxygen, right? When you call it doesn't move, the contrast is not going to move, nor forward or backward. And that's where ischemia happens. Conus supplies the right ventricular outflow. And the RVOT is a very sensitive area to develop VFib. And it can happen within seconds. And as a fellow, it happened to me. It happened, I'm pretty sure who did a lot of cath, the same concept that happens. And then you have to react fast. You have to take it out and do not panic and react accordingly. But usually, if you recognize it early and avoid this happening, you're in safe grounds. So that's why when it happens, you have to keep an eye. You have to have the good peripheral vision, not only manipulating the catheter, looking at the hemodynamics while you're doing that procedure. So always make sure that that waveforms that you saw, the dampening and ventricularization, does not happen. Okay. Usually in the cath lab, you have a code with your team. Usually the code I have with my team is CONUS. You don't want to say, do not say really big words because we're dealing with an awake patient. So develop a code with you and your technician and the team that what's the best term before you, if the technician or one of your colleagues witness this kind of waveform. So why it happens? So what happened is actually a reflection of ventricular systole. So once a contraction happens, what you see is the transmission of pressure within the ventricle into the artery because your catheter is completely against the wall. and that's the transmission of the pressure to that. So the next question is that if you see dampening before you engage the coronary, what's your differential? It's one of three. It's either there is air within the catheter, there is a clot within the catheter, or with a lot of manipulation, especially you're starting your cath lab rotation, you're going to twist the catheter, and that's where it happens. So you have to recognize that fast. Once you see that, even you're really manipulating the catheter, you try to untwist what you did. If you think there's clot, you do not inject. You try to withdraw and discard the clot. And if you think it's air, the same concept. You have to de-air it. What about dampening after coronary engagement? It's either you have a severe osteal lesion, or you have osteospasm at the tip of your catheter, or you have a size mismatch where your catheter and the size of the vessel, there's a big difference. The catheter is so big and the vessel is small, so you're going to have this waveform. Or your catheter position is not coaxial, it's hitting the wall, or a plaque. And that's what to recognize these things and act accordingly. If you're going to do, sometimes you have no choice. You need to do a PCI for osteal lesion. Then you might need to use a side hole guide. So you perfuse some blood within the vessel to avoid ischemia to the vessel. Okay, so I wanted to start here with another case. This is a difficult case, but if you go methodologically, I guarantee you will reach to the diagnosis. Okay? So here I want to give you about 30 seconds to look at the pressure tracing and the rhythm. Do as I said, look at the rhythm, look at the wave pressure tracing, and then correlate it together, and then try to guess what is the pressure tracing for each. You have 30 seconds to look at it. Okay, so let's go by one. So here's the rhythm. What do you think? You have a P wave and a QRS, T wave. So you can say it's a sinus. So you should generate an A wave, correct? You don't have any PVCs gonna really disrupt your pressure tracing. You do not have AFib. So you have a clear T wave that you can correlate the waveform. Then you have two pressure tracings, okay? You have one, this wiggly pressure trace waveform, okay? This is reality. This is what you're gonna see. And you can see here, there's a lot of artifacts. And here is pretty clean, another tracing. So let's start with this small one. You can tell from here the numbers is very low numbers, because it's this or this. So it's very likely it's going to be right-sided. It's not always, but let's assume that's the case. It's a right-sided chamber for both of them. Here, you want to look, how does it behave in diastole? So here at the end of T wave, so this is where diastole starts, and here's the QRS. So here, diastole from here to here, okay? So how does this waveform look here? It's not downsloping. Do you think it's downsloping, upsloping, or horizontal here? You really can't tell, but here it starts to clear out. So it looks here downsloping, more clearer over here, over here, over here. Okay, so let's assume this is the case. So this is a downsloping. and you have one peak within the SCT segment. If you look at the cleaner one, but there's a lot of artifact that you can see. Okay, I would consider this based on the downslope in the diastolic phase. Then I would call this is an arterial pressure tracing. What about this waveform? Okay, you see there's only one peak, so it's either going to be ventricular or arterial, right? But look at diastole. You can't see really clear if there's any A wave here, maybe this one here, but there's a lot of wiggle you cannot trust. So you would not rely on that as a differentiator. But if you look at the diastole, it's actually upsloping, right? Or horizontal here. So this is like, given it's one peak, not two peaks like an atrial, and it's upsloping and some horizontal, then this is a likely a ventricular tracing. So this is an artery. We say it's a right-sided, so it must be a pulmonary artery. And this is a ventricular, and we said right-sided, there must be an RV, right ventricular. Okay. Then you want to analyze for pathologies. So you can see here, it looks there is a gradient between arterial, system, PA, and ventricular over here, the whole thing. This shouldn't be, these should be overlapping, right? If you look back here, you see how the ventricle overlaps the arterial. Here, it doesn't. So there must be a gradient between the pulmonary artery and the right ventricle. So your catheter in the pulmonary artery and other catheter in the right ventricle. So you know there's a gradient. So what's your differential? So is this pulmonary stenosis, right? But you pull your catheter lower down from the PA to the right ventricle, and you see this. So what do you see? The same thing, an arterial waveform. This is, but this is different now. The diastole is becoming overlapped, and it's actually not downsloping, it's actually upsloping, like ventricular tracing. You can see it's overlapping diastole. Compared to here, it is not. Here is downsloping, and here is upsloping. Here, they're both an upslope during diastole. There's only one peak here, and one, let's assume it's a one peak because there's a lot of wiggle artifact. So, but how this can be explained? So tell you that both are within the same chamber, but there is a gradient. So there must be a gradient within the ventricle. And this is what happened. This is the proximal RV, and you have the distal RV. And this is an intraventricular gradient. So what kind of pathology is this? There's different types of pulmonary stenosis. There is branch, supravalvular, and valvular, and subvalvular. And this is very rare. If you didn't go methodologically with your catheter, you try to identify, is this a problem within the valve, above the valve, or below the valve? Already with that tracing, we can tell there is a gradient within the pulmonary artery and the right ventricle. But if you pull the catheter, it's actually subvalvular. which we called infundibular pulmonary stenosis. Uncommon, but this is a classic finding of infundibular pulmonary stenosis. So if you go methodologically, if you try just to look at pattern recognition, it's really not helpful. And that's why you really have to go, it doesn't come clean as the books. It's actually, this is reality. It comes with a lot of artifacts, and you have to collect data in a way that makes sense. And here, this is a good exercise in how to identify what type of chamber based on the approach we talked earlier. So usually the treatment of pulmonary stenosis is percutaneously. Before, we usually use a lot of Melody valve. Currently, we start to use more with Edward Sapien 3, more conveniently. But before you do that, to commit to put a valve, you have to test. You have to balloon first. Why is that? You see here in your left side, you balloon, and then you see if you do it, a balloon test. You see if there's any compression on the left system, and you can see it is actually happening. And this is the time you do not put the valve from coronary flow and patient arrest. So always, it's a default strategy to test the coronaries before you embark in a valve deployment in the pulmonary level. And you can see here why we're saying that. This is the aortic valve. You see here the pulmonary valve, and this is where the left main takes off. And if you balloon here, you might compress the left system, whether in the left main level, if you go lower, you might in the LED level, as we saw in the previous example. Okay. Any questions about that case?
Yeah, Dr. Waleed. So let's review again, if you don't mind.
Sure.
The steps again. So first, you identify if it's right ventricle or left ventricle, and you do
Right.
that. And you do that by how?
So the right ventricle, left ventricle is not important, but you can tell from the numbers here. You see how the numbers here? If you see low numbers, usually, most of the time, it is a right-sided chamber.
Right.
It's not the case usually, but it doesn't matter if right or left. I will tell you. Most of the time, we tell you. If you know where are you, in the left system or in the right system when you do your hemodynamics. But in general, here, I'm telling you it's a right system, and you can't tell from the numbers. But that's not an important step. I never put it as an approach here. My approach, what I need you to know is this. I wanted to identify the rhythm, the wave, and then correlate both. When you analyze the wave, you answer those 4 questions. What happens in diastole? Is the pressure tracing sloping or horizontal? The timing of the pressure peak within the STT segment. How many waves or peaks for every QRS? Is it dichrotic notch or an A wave? Those are the 2 important slides that I need you to know. And based on that, you can analyze any pressure tracing. As you see here, again, systole start from QRS and ends at the end of T wave. Okay. In arterial and ventricular, there's only 1 peak. Compared to atrial, there is 2 peaks, the A wave and the V wave for each QRS. Okay. Then what happens in diastole? In diastole here, in ventricular tracing, usually it goes upslope or horizontal. The same thing for the atrial, it's horizontal most of the time. In arterial, it's the only one that goes downsloping at the end. Okay, so that's for what happened diastole. The timing of pressure peaks. This is happening within the STT segments. The V wave and the A wave usually out of that STT segment. Is there dichrotic notch? In arterial wave, you always have a dichrotic notch. not always, but you will have. Another pressure tracing, the ventricular atrial, they don't have, but they have an A wave. The atrial pressure and the ventricular pressure both have an A wave. So this is the way to differentiate between the two. So that's what I needed to know. About right-sided, left-sided, it's a guessing game, but we always tell you, I know you always know where your characters.
Dr. Waleed, we have
Any more questions about it?
yeah, we have a question by
Sure.
Dr. Natiq. He's raising his hand.
Yes, Assalamu alaikum, Dr. Waleed.
Salam rahmatullah. Long time, I didn't hear your voice.
Yes, long time.
Yeah.
دكتور بس I have a question في الفيرست سلايد اللي هي pulmonary artery and RV الهيموداينامكس.
Okay.
The first case.
Yes.
Yes. Is it like spike and doom في pulmonary artery or this is just only artifact?
It's all artifact. You can't tell. You can't tell. It's really, it's all the time. It's there. Whenever you see this behavior, you know, this is what we call whipping artifact. It happened when the catheter moves. And this is not a square root. There's a case I'll show you what is spike and dome morphology looks like.
And can it happen في the right side or only and exclusive في left spike and dome?
Spike and dome?
Yeah.
It can happen in the right side, but it's most commonly happen in the left. Okay. Whatever happens in the left happens in the right.
Okay.
But we don't see it much. That's the thing. For reasons that we'll know. If Abdulaziz give me a chance to give another talk, we'll talk about it.
Okay, thank you very much.
So inshallah, we'll have many more talks.
Any more questions?
No more questions. We can
Okay.
proceed.
Okay, I want to take 30 seconds to look at this tracing.
Dr. Waleed, what do you think? Should we ask participants to participate in the case? Like, should I pick somebody?
I prefer not.
Okay.
If you do that, it's because there's variability between levels, and it's better. I'll take the lead. I just wanted to test yourselves. I wanted to write, what do you think the diagnosis? You'll go methodologically the same way we talked about, just as a habit. I wanted to develop the habit. I don't care if you reach the diagnosis, to be honest. I just wanted to develop the habit, and then you challenge yourself how to apply that. Myself, even though I still now as a consultant, over many years, I still sometimes scratch my head and think and make mistakes, and I enjoy the whole thinking process. So it's mainly I just wanted to develop the habit. Okay, so we'll start. Look at the rhythm. Can you see a clear P wave? Barely not, maybe a hint, but you barely not see it. So you anticipate you might not see an A wave, or maybe it's just a low voltage. But regardless, you can see here, tiny P waves. So you assume you need to have an A wave, you're gonna see that. And you have no extra beats, whether atrial or ventricular systoles. So it's not gonna disrupt your pressure tracing analysis. Because once you see it, it might disrupt or might help you in pathologies like in hypertrophic cardiomyopathy and broken which is in another case. So let's start with one of them. I just start with the small one, okay? Let's start with this, okay? So let's go, I usually love the diastole, what's happening there. So you can see here, what's happening here in diastole. It's kinda it's really not going down as we expected, but you can say it's a bit horizontal. It's a bit maybe downslope a little bit, but let's assume it is a downslope here and horizontal over here. So you're not sure. You're not sure because this always differentiate between arterial versus ventricular arteria. So here it doesn't help me much. So we go to, for each QRS, how many peaks we have? Clearly you have 2 peaks, right? So we have 2 peaks in each QRS. Oh, okay. So this is going more with atrial. Next, is there an A wave? Well, you suspecting this is an A wave base, you have a P wave in the rhythm. So yeah, maybe that's an A wave. Next, you want to see the peaks of those 2. Are they within the STT segment or not? They're not. They're not within the STT segment. Maybe the V wave is becoming within the T wave, as you see. But I can bet this is an atrial tracing, despite there's some variability that is not against it. But I would say this is an atrial tracing. Okay. Then go to the second tracing. You see here, you go to diastole. So here you can see it's upslope, upslope, upslope. So this is not arterial for sure. So it's either ventricular or atrial. Let's look at the peaks. How many peaks for each QRS? It's only 1 peak. Okay, that goes with ventricular now. Let's confirm it more. Is there an A wave? No, I don't see a clear A wave. There's a lot of wiggle, but I can't say there's an A wave. Okay, so that's not helpful. Then you say, is the peak within the STT segment? It is. So this is a ventricular tracing. So you see the pressure is very high here, 100 it is. So this is assuming a left ventricle, and this is a left atrium. So you identified the chambers. Now, into pathology. So you correlated. What's happening here? In diastole, they should overlap, right? In diastole, they should be together. There should be no gradient. But here, there is. You see, there's a gradient here. Usually the gradient happens early, but this isn't the whole phase of diastole. So there is a gradient between the left atrium and the left ventricle. So what does that tell you? There's an AV level stenosis. What's the cause of that? It's a differential. But most commonly, you're going to see that in mitral stenosis. So there is a gradient in mitral stenosis. So then you see this. So what procedure performed here? You see the gradient came lower compared, but something bad happened. Look what happened. The V wave becomes so large and it's high. And you know, when we call V wave ventricularized waveform, this is what we call ventricularized waveform, because it's starting to become in the ventricular territory, which is the STT segment. And this is a sign of severe mitral regurgitation. So what happened is that a complication of percutaneous balloon mitral valvuloplasty. You fix this, you probably lowered the gradient, but you caused a complication. And this was supposedly to be picked up earlier because you already have a large V wave. They tell you that at least this is a moderate mitral regurgitation, which is a contraindication for percutaneous balloon valvuloplasty. So here, if someone analyzed this waveform appropriately, he would not embark on a mitral balloon valvuloplasty and send the patient for surgery. And this is what happened, okay? You have an LA waveform, an LV, and then you have a giant V wave. Any question about this case?
Clear.
Good. Okay. We'll go again here. Have a 30 seconds, review this. Go, if you have a paper, write down exactly the approach, and then try to collect it together, make sense of what data you have. You jumped it. Okay. I jumped before I, sorry for that. You saw the answer already, but let me take out this one. Okay. So let's go back to the rhythm. You can see there's maybe a tiny A wave. Here is flat, but you see there is some peak here after the P wave. So assuming this is a low voltage, but I think there's a P wave. There's no extrasystoles. Pretty regular, so it's not like the AFib. So I would say there's an A wave here, tiny, but it's not really clear here. And then you go look at the pressure tracing. You have two pressure tracings. Again, look at the scale here. Very likely this is the right side of the chambers because it's a low pressure system. You can see here in this pressure waveform, try to pick the diastole time. In diastole, it looks horizontal. Okay, so this must be atrial versus ventricular. Okay, so how many peaks for each QRS? There is one and there's two. So actually this goes with atrial. There is an A wave. And the peaks of those two are outside of the STT segment. So I would call this a right atrial go to tracing. Here, look at diastole. What happens? It's actually upslope, right? Upslope. So this is ventricular versus atrial. Look at the peak. How many peaks for every QRS? Only one. So that's goes with ventricular. The peak is within the STT segment. So that goes with ventricular. So I have an RA and RV. What happens? Then you want to look at the pathologies. What's going on? You look here. It is normal that you see difference between the systolic NRV and the atrial pressure tracing. So that's not a problem. The problem is here. They should be equal and overlap. Here, it's not the case, okay? So you see there's a gradient. So there must be an obstruction at the level of the tricuspid valve. In addition, you see the A wave here, شوف A wave, is bigger or equal to the V wave. So you have a giant A wave, which is persistent. Here. So that's all goes with tricuspid. You have a giant A wave and you have the diastolic gradient between the RA and the RV. So what's the differential of a large A wave? And what's the differential of a Canon A wave? Before we ask the two questions, what's the difference between a large A wave or a Canon A wave? As a definition. This is a question I would, Abdulaziz, ask the audience. If anyone knows, he can speak up, unmute and talk. What's the difference between a large A wave or a Canon A wave?
The large A, can I answer?
Yes, who's this first?
Dr. Reem from Saud Al-Babtin Cardiac Center in Dammam.
Hayak Allah, Dr. Reem. Yes,
hello, doctor.
Go ahead.
Large A wave, we can name like this when there is P wave for every QRS. So there is atrial ventricular association. But the Canon A wave can be only seen when there is AV dissociation versus an AV block or VTAC.
Ahsanti. This is the perfect answer for this question. Exactly. There in large A wave, there is an arterial, there is an AV association. You're gonna see it persistently, as Dr. Reem mentioned. And Canon A wave, usually it's not persistent. There is an AV dissociation. So you see it intermittently large and variable in the size of the A wave. Excellent. So what's the differential of a large A wave? Anyone can answer?
Yes, on the right side, the large A wave can be. I am Dr. Saleh from BACC.
حياك الله دكتور صالح. ممتاز.
From the right side, we can see it in the maybe in the tricuspid stenosis. Also on the pulmonary hypertension, pulmonary hypertension sometimes RV dysfunction. On the left side, in the mitral stenosis, and we can see it also by the other effect in severe aortic stenosis. On the right side.
So, okay. So, excellent job, Dr. Saleh. So, usually when we test someone, to understand so we don't forget differentials, that was an excellent question, Dr. Saleh. But I prefer when you answer it in a way with a pathophysiology. So to tell you that I understand, حتى لو ما جبت other differential, if you tell them the pathophysiology, the same thing when I asked about the difference between large and Canon A wave, Dr. Reem said AV association versus AV dissociation. This answer make me, she understands what she's talking about. And even if she missed the diagnosis or something like that, we know that she understands the pathophysiology. The same thing here. I usually prefer to go with pathophysiology. It's either one of three. Either you have an increased RV EDP, okay, and that's reflection of a reduced RV compliance, and that happen in ventricular hypertrophy, pulmonic stenosis, pulmonary hypertension. Okay, so those are the three pathologies that happen under the pathophysiology whenever you have an increased right ventricular end diastolic pressure. Okay, the second mechanism, if you have an increased AV gradient. And like in our case, tricuspid, and that's why when I said I didn't commit myself to tricuspid, I said it's most likely, but I would say there is an obstruction at the AV level. So if you have tricuspid, RA myxoma, RA thrombus, all they can cause an increased atrioventricular gradient, okay, or a Bernheim effect. The Bernheim effect, it can happen, as you mentioned, Dr. Saleh, beautifully. It can happen in mitral regurgitation, aortic stenosis, hypertrophic cardiomyopathy. And your homework today, if you go back, read about Bernheim effect and reverse Bernheim effect. It is a beautiful mechanism. If you understand why the large I wave happens. It's a very simple concept. Or we can talk about it in a different session, but it's very simple concept. But those are three mechanisms of a etiology of a large A wave. Okay, the Canon A wave, and that's what happened. What Dr. Reem mentioned about AV dissociation, and you have three causes can cause that. If you have VTAC, you have a complete AV block, or you have a VVI pacing. Those are three things that cause AV dissociation where you can have a Canon A wave. Absent A wave, like an AFib, okay, and F waves, and that's where sometimes you can't see it in a JVP, but you would see it sometimes in a hemodynamic tracing, like an atrial flutter. So if you know this slide, you will never miss anything about A wave. Any questions?
Can I just comment on Bernheim effect?
Go ahead, Doctor.
what I remember that about this effect, that it's related to the LVH or hypertrophy, especially on the interventricular septum. So, or in the mitral regurg, the dilated left ventricle will cause some pressure effect on the interventricular septum, causing right ventricle failure or RV increased RVEDP. So in such cases, we will have the A wave. I don't know, doctor, if it's the right or not.
Who is this talking?
The Bernheim effect, which happens in AS or HACM.
No.
It will, yeah.
I just want to know who's the person talking.
Yes, I'm Dr. Reen, doctor.
Dr. Reen. Yes, you're right. You're right about the mechanism. So it's purely a diastolic event. صح ولا لا؟ قلنا ال A wave is a diastolic event. So what happened in mitral regurgitation? What happened? You have a volume overload, and that's where the LV get dilated, and that's gonna push the interventricular septum, as you said, during diastole. And when the right atrium tries to squeeze, do the atrial kick against a smaller cavity because it's getting pushed by the left ventricle. It's better visualized. The same thing for aortic stenosis. If you have LVH, severe LVH, that start to compromise, encroach into the right ventricle, that's gonna give a harder time for the right atrium to squeeze the preload to the right ventricle, and that's what's gonna cause a large A wave. And the same concept happens in hypertrophic cardiomyopathy. And that's what Dr. Saleh, why he said put those under the differential beautifully. But you're right, that's the mechanism. And it's beautiful. If I show you the echoes, I have a full slides about this Bernheim effect with echo images and how it looks in pressure tracing, inshallah, in another setting with Allah. But I wanted to look also about the reverse Bernheim effect. Any questions?
No questions.
Okay. So I'll go back again for those who came late. The goal of hemodynamics, you always want to correlate physiology, the physical exam findings. So for example, as we saw here, an A wave prominent, you can see it in the JVP exam. An echo, you're going to see the findings. And pressure tracing, you're going to see all these findings. So when you correlate, when you understand really hemodynamics, you really understand cardiology very well. That's very important. And what you need when you study for it, it's a very big area. You can't, but you try to focus and develop an approach of reading pressure tracing. So by this way, even in OSCE and on exams, even in clinical life, you really, you will not make shortcuts, and you always be methodologic when you try to interpret pressure tracings. Remember the hemodynamic calculations. My colleague is going to present it, and develop a disease-oriented correlation. Understand how hemodynamics show or reveal in each pathology, and if it's mixed, like we saw in mitral stenosis, that is complicated by mitral regurgitation. And then go with a methodology of approach to waveform analysis, going over the rhythm, the wave, correlation between the two, and then answer the 4 questions to identify where is this chamber is in, and then you correlate to find the pathology accordingly. Thank you very much for your time.